All right, well, thank you very much for that very kind introduction. Thank you very much for this very kind invitation to speak on immune thrombocytopenia. I'm going to be talking today about some new studies, but sort of new studies of old agents, management of ITP in certain special populations like pregnant patients and those with more refractory disease, as well as novel therapies in ITP. I'm going to try to do all of this in just 25 minutes. So here are my disclosures. All right, so we're going to start with new studies of new and old therapies for ITP, as well as use in special populations. So I like to start a discussion with ITP by talking about splenectomy, because if we don't start with it, then it may get overshadowed or we may forget about it. So splenectomy, if we look at the old data, the data that has been really guiding our discussion with patients for many decades at this point, the old data says that if you take an ITP patient and you do a splenectomy in that patient, that you will essentially cure them of their ITP about 2/3 of the time. About 2/3 of patients will have a durable response to splenectomy that lasts. And so, this data, it's important to recognize this data came from a time when splenectomy was being used much earlier in the treatment course of patients with ITP. Patients would receive steroids, perhaps IVIG, they would fail those things, and then they would go to splenectomy. So it was basically a second-line therapy option. But as you can see from the graph I have here on the right-hand side of this slide, the rate of splenectomy over time has been declining, and this graph ends in 2009, and if we go even farther, then the decline continues. It's now really a substantial minority of ITP patients, less than 10% of ITP patients, that are ever getting a splenectomy. So we have to consider that in those patients that are receiving and failing rituximab and thrombopoietin receptor agonists, or perhaps multiple thrombopoietin receptor agonists, and fostamatinib, all of these newer therapy options, are we going to have the same success rate? Is it going to be the 2/3 rate of cure, the 66% rate of cure? Well, as it turns out, looking at a new study that was published by the French group just this past year, in fact, we don't have rates that are quite so good. Now, it wasn't a huge number of patients in this study that had received thrombopoietin receptor agonists and rituximab and failed those things, who then had splenectomy. But this did have a decent number of those patients, and the success rate was about 45%. So it was certainly less than 2/3, less than half, about half. But it's important to recognize that the success rate of splenectomy in a patient that's already tried and failed these other therapies isn't quite as good as the historical data that we previously have been quoting, around 70%. Predictors of non-response to splenectomy included an age greater than 75 years and more than 4 lines of therapy. So these are things that we should discuss with our patients in 2022 when we talk about doing splenectomy. One thing that was found in this study was that sometimes those patients who did not respond to thrombopoietin receptor agonists prior to their splenectomy then actually did respond once they had the splenectomy. So they did not respond to thrombopoietin receptor agonists, they had a splenectomy, they failed the splenectomy, their disease relapsed after splenectomy, but once their spleen was out, they actually did respond to the thrombopoietin receptor agonists that they didn't before. Now, this is not an advocation in any way to do a splenectomy to get patients to respond to thrombopoietin receptor agonists where they failed, but it's just something to consider in those patients who ultimately have failed thrombopoietin receptor agonists, go to splenectomy, and then fail the splenectomy. You may be able to try the same thrombopoietin receptor agonist that previously failed. I also like to just remind everybody about rituximab. Okay, so rituximab, over a decade ago, when it was initially being trialed in ITP, was felt to be very promising, 50 to 60% rate of response, which is great. as we see on this graph, 57% rate of initial response. That's wonderful. However, we have to recognize that for the vast majority of those patients, this is not a durable response. I like to call rituximab like a very sticky Band-Aid that eventually comes off. By year 5, the response rate is about 20%, which is similar to the spontaneous remission rate in ITP patients just generally. So we recognize that rituximab can be helpful, but that we're probably not curing very many patients with rituximab. That's something to recognize. So now just a bit on the thrombopoietin receptor agonists that we already have available to us. If we look at the prescribing information for L-Trombopag, it's dosed once daily, right? That's how we dose it. We give 75 or 50 or 25 or 12.5 milligrams once daily, every day. However, there is now data, some from our group, some from others, showing that it's actually acceptable in many patients to dose L-Trombopag less frequently than once daily. This could be a means to reduce cost, of course, and all we're looking to do here is maintain a minimally acceptable platelet count, right? We want a platelet count ideally above 20 to 30,000 and the patient's not bleeding. And in many cases, we can do that we can accomplish that with less frequent than once daily dosing by going to 5 days a week, and then 4 days a week, and then 3, and so on and so forth, basically stopping that taper when the patient starts to have a platelet count that's coming unacceptably low. And we do this slowly. Over the course of several weeks, you can get the patient down to fewer doses of L-Trombopag than once daily. By the way, avatrombopag, our newest thrombopoietin receptor agonist in ITP, the prescribing information already instructs a tapering in this way. The dose titration actually involves dosing the same amount, 20 milligrams, less frequently than once daily. We can do this with the thrombopoietin receptor agonist because of the pharmacodynamics of how the drugs work and just simply the kinetics of thrombopoiesis. It takes 5 to 7 days for these agents to have an impact on the megakaryocytes and megakaryocyte precursors. And of course, we dose rimiplostim once weekly. So now I want to talk a little bit about thrombopoietin receptor agonists in pregnant patients. So what I have here is from a study that was published in Blood just about 1 to 2 years ago, relatively recently, that looked at 15 women with ITP exposed to at least one thrombopoietin receptor agonist during pregnancy. Okay, so some of these exposures were intentional in that the patient did not respond to anything and had terrible ITP, and so the decision was made to put them on L-Trombopag or rimiplostim despite the fact that they were pregnant. And some were unintentional, right? A patient became pregnant while taking one of these agents, didn't necessarily realize they were on it. So this is a small case series of 15 patients, but the overall response rate was 77%. Most of that response was in combination with concomitant ITP therapy. So thrombopoietin receptor agonists in combination with, say, azathioprine or steroids. There was no negative impact on mom or baby in the patients included in this retrospective study. So an initial first salvo to help us understand if these agents are safe for pregnant women. A more recent study looking at just rimiplostim and significantly more patients, about 4 times as many patients, came to just recently published in the American Journal of Hematology from Dr. Bissell and his group just a few weeks, just within the last few weeks, this study was published, showing relatively similar outcomes. In other words, there was really no evidence that rimiplostim caused any sort of negative outcome on the pregnancy. We recognize that complications in pregnancies of women with ITP are just more likely than the general population in any case. Many of these patients have very difficult to control disease and very severe thrombocytopenia. It may be very challenging to do epidural anesthesia and maybe more challenging to deliver safely. There's all sorts of complications that we can see, but in this study, it really did not seem as though there was any negative impact on the babies that were born or the mothers receiving romiplastim. So another reassuring study for use of thrombopoietin receptor agonists in pregnant women. Now I'm going to just briefly talk about avatrombopag. I mentioned it briefly before, but just to remind everyone, this is a newer thrombopoietin receptor agonist that, unlike it is oral like L-trombopag, but unlike L-trombopag, does not have the same issues with dietary restrictions, does not have the same issues with hepatotoxicity that we see. About 10% of patients with L-trombopag can develop hepatotoxicity, and L-trombopag requires essentially fasting for 4 to 6 hours around taking the pill to ensure its adequate and proper absorption. That is not the case for avatrombopag. It can be taken with food or without food. The prescribing information actually recommends taking it with food. The downside with avatrombopag, of course, is that we don't have, over a decade of experience and safety data and such with this agent. Obviously, with more time, there will be more safety data. I remind everyone that if a patient does not respond to one thrombopoietin receptor agonist, they may respond to another. All right, so there's quite a lot of data published showing transition between L-trombopag and romiplastim, and from romiplastim to L-trombopag. This is an example here of a patient that was treated with all three drugs, and you can see the differential response to each, right? So this patient, a baseline at a platelet count of 10,000, they were bleeding. They went on avatrombopag. This was on a clinical trial many years ago. They went on avatrombopag. That's why the doses are in 10 milligram increments rather than 20 milligram, because normally avatrombopag is now dosed in 20 milligram increments, and we see that their platelet count responded very nicely to avatrombopag. The trial ended after 15 weeks. They wanted to be on a oral drug, and so they went on L-trombopag. They did not respond very well to L-trombopag despite dose titration to max dose L-trombopag. So then we're switched to romiplastim, and you can see they responded very robustly to romiplastim with even at low dose romiplastim, 1 microgram per kilogram per week with high platelet counts. Now, this is not to say that there's anything special specifically about any one thrombopoietin receptor agonist. Patients may not respond to one and respond very well to the other two, or may not respond well to two, but respond well to a third. These figures are from a study we recently published evaluating patients who previously were treated with romiplastim and or L-trombopag, who were then switched to avatrombopag. And panel A on the left, this is the whole population of 44 patients. Some were switched for convenience, right? They wanted to get off of an injectable, or they wanted to get rid of their dietary requirements. Some patients were switched for adverse events. Some patients were switched because of inadequate effectiveness, right? So 13 of the 44 patients were switched because romiplastim or L-trombopag was not adequately effective, and so they were switched to avatrombopag. We see that they had improved platelet counts as the cohort did on avatrombopag. And then in panel B, this is limited to just those 13 patients who had inadequate response to L-trombopag or romiplastim, and we see that they had a significant improvement in their median platelet count on avatrombopag. Briefly, just to mention fostamatinib, our spleen tyrosine kinase inhibitor in ITP. This trial looked at patients with highly relapsed refractory ITP. Patients who received a median of 4 or 5 prior therapies, and the proportion of stable responders was about 18% in patients receiving fostamatinib, 2% in placebo. Newer data shows, though, that line of therapy matters, just like with most patients, just like with splenectomy. If we give fostamatinib earlier on in the treatment course, we can see that the rate of response, in fact, can be much higher than that 18% number. So highest in the second line, then third line, then fourth line, fifth line, and so on and so forth. This is just a single response of greater than 50,000 rather than a stable response, but when patients do respond, we can see in panel B, it doesn't matter what line, when they have a response, that response tends to be durable. All right. So I briefly want to just mention a recent, very important study that was published in the New England Journal of Medicine last year called the FLIGHT study, looking at mycophenolate plus steroids versus steroids alone for first-line ITP treatment. If we look at these curves, we can see one thing you might notice is very high durable response rates in both groups, which is definitely true. The corticosteroid-only group had a much higher rate of durable response than one would have expected out of corticosteroid only. But nonetheless, the patients given mycophenolate did have a higher rate of durable response. You might say, why is this not the standard of care right now? Well, the quality of life measurements in the study actually showed that the patients in the combined group had reported worse quality of life than the patients in the glucocorticoid only arm. Now, not significant. I mean, it was statistically significant. It wasn't a massive gulf between the two groups, but I think it just goes to show that more is not always better, and we have to remember quality of life in ITP. After all, ITP, the whole our goal in treating patients with ITP is preventing bleeding while maximizing quality of life and minimizing toxicity from therapy. In the last 10 minutes here, I'm just going to touch on some investigational therapeutics in ITP. I think it's remarkable that in just 2 decades, ITP has gone from steroids, splenectomy, and salvage therapies to many targeted therapies. We already talked about the thrombopoietin receptor agonists, of course, and the anti-CD20 antibody rituximab, as well as the spleen tyrosine kinase inhibitor fostamatinib. I'm going to cover some additional therapeutics like complement inhibitors, as well as BTK inhibitors and neonatal FC receptor antagonist blockers, just briefly. So what is a neonatal FC receptor? So the neonatal FC receptor is a receptor that is responsible for the high half-life of circulating IgG, of its approximately 3-week half-life. If you block the neonatal FC receptor, then you drop the half-life of IgG by 2/3. You drop it to about 1 week. And when you do that, you drop the concentration of IgG by about 2/3. And therefore, you drop the concentration of pathologic autoantibodies by about 2/3. And so this mechanism holds a lot of promise for the treatment of patients with humoral autoimmunity, antibody-based diseases, of which ITP is known to have a major component caused by platelet autoantibodies. This class of agents is actually already approved to treat myasthenia gravis, another autoimmune disorder that is mediated by autoantibodies. And so there are 2 drugs I'll mention. The first is efgartigimod. So efgartigimod is a human IgG1 antibody FC fragment designed to have increased affinity to the neonatal FC receptor, preventing IgG recycling and causing targeted IgG degradation. It's administered either subcutaneously or intravenously. This was a phase 2 study in which patients who were generally multiply refractory ITP had received, most of them had received 3, 4, 5 prior lines of therapy. These patients they were randomized 1:1 to receive 4 weekly intravenous infusions of either placebo or efgartigimod at 5 milligrams per kilogram or 10 milligrams per kilogram. The patients receiving efgartigimod had a rapid reduction in their total IgG levels by about 2/3, which was associated with clinically relevant increases in platelet counts. And we see here, if we look at just one response of a platelet count greater than 50, the placebo patients in gray did pretty well. But when we say at least twice, then the efgartigimod patients did much better. And then when we say more than 10 consecutive days, that happened for no placebo patient and about half of the ITP patients receiving efgartigimod. This drug pretty well tolerated, with headache as the primary adverse event seen in that study. Rosenolixizumab is another neonatal FC receptor antagonist. Rosenolixizumab also evaluated, this is a humanized high affinity subcutaneously administered FcRn antagonist. This here I have is from a phase 2 study showing the percentage of patients achieving a platelet count greater than 50,000 treated at various dose cohorts of rosenolixizumab. So this drug does work in ITP. There was a phase 3 study that was ongoing, but just in August it was announced that it had been terminated in ITP, the phase 3 study in ITP, for a strategic business decision. So unclear if this drug is going to have any further development in ITP, but just proof of concept of the mechanism of neonatal FC receptor antagonism. So I'm briefly now going to talk about BTK inhibitors in ITP. So BTK inhibitors are inhibitors of Bruton tyrosine kinase, commonly employed to treat lymphoid malignancies. They have a profound impact on B cells. And we also recognize that patients who have non-Hodgkin lymphoma complicated by ITP receiving ibrutinib and other BTK inhibitors can go into a nice remission of their ITP. There's interest in evaluating these drugs for the treatment of ITP. So a recent, very important New England Journal of Medicine paper published this year looking at rilzabrutinib, a highly selective inhibitor of the Bruton's tyrosine kinase that's been evaluated. This was a phase 1/2 study in patients who had chronic ITP, very severe refractory chronic ITP, median of 5 prior treatments. They had disease duration of over 6 years. So this is the most refractory sort of population that we see in a clinical trial. Despite having this very refractory disease, 40% of patients achieved a good response to rilzabrutinib. And patients who did respond, 65% of their assessments had a platelet count of greater than 50,000. When patients tend to respond, they tend to have a nice durable response that's stable to this drug. Most common adverse events were GI sort of things, nausea, diarrhea, but relatively low grade and tolerable. And so there's now a phase 3 study of rilzabrutinib in ITP. This is also from the rilzabrutinib study. This just goes to show that that 40% response rate was relatively regardless of the type of population, right? So perhaps they had previous splenectomy, doesn't matter. Therefore, their response rate was still around 40%. No previous splenectomy, doesn't matter. Chronic ITP versus non-chronic ITP. Patients treated with multiple therapies, it didn't really matter. The response rate was around 40%. You might be concerned about using a BTK inhibitor in a disease like ITP, a bleeding disorder, a platelet disorder, right? So in BTK inhibitors, ibrutinib poisons platelets, reduces platelet aggregation. Acalabrutinib poisons platelets. These other BTK inhibitors can reduce platelet function. And so we may have a concern about doing that in ITP, right? Well, it turns out rilzabrutinib is much more selective. PRN1008 is another name for rilzabrutinib. It's much more selective than ibrutinib is in terms of the kinases that it inhibits. And when we look at the effect on platelet aggregation, we see that in healthy volunteers, ibrutinib has a significant impact on platelet aggregation. When we compare that to ITP patients with rilzabrutinib as well as healthy volunteers on rilzabrutinib, we see no significant impact on light transmission platelet aggregometry on the aggregation of platelets. So that makes us feel comfortable. And also in the clinical trial, right, we didn't have a whole bunch of untoward bleeding events in patients who are on rilzabrutinib who had responded. Just a brief word about a new thrombopoietin receptor agonist called hetrombopag. This is currently approved in China to treat ITP and aplastic anemia. Recent large study in China was published showing it to be efficacious in ITP compared to placebo, very similar to our other thrombopoietin receptor agonists. Like L-trombopag, this drug does have relevant food interactions with absorption reduced when taken with certain foods, so that's important to note. Unclear if this drug is going to be developed outside of China, but just to show you that. And lastly, just to talk about complement inhibition in ITP. So sutimlimab is a complement C1s inhibitor, a monoclonal antibody that inhibits complement C1s. This drug is already FDA approved in the United States to treat cold agglutinin disease, another complement-mediated condition. And we recognize that the platelets of patients with ITP are coated with complement, and that complement likely plays a role in the destruction of platelets in the pathophysiology of ITP. And so in a phase 1 study of sutimlimab in refractory ITP, patients receiving sutimlimab infusions every 2 weeks, you can see at the very beginning on the left here of this graph, we see that patients have complement functional assay, which is in green, drops dramatically while their platelet count comes up very nicely. And so long as you maintain those every 2-week infusions of sutimlimab, their platelet count stays up. And then there was a washout where they stop the drug, the platelet count plummets, complement functional activity comes back up to normal. Then when you restart the drug in the second half of the study here, the platelet count recovered and complement functional activity then dropped. So about half of patients in the study had a nice response to sutimlimab. There were responses in as early as 4 to 8 hours after the first infusion. So when you have the platelet count rising that quickly, that's very exciting. Potentially in ITP, we need to see this borne out in future studies with more patients. But right now, even IVIG takes 1 to 2 days to raise the platelet count. So if we can raise it within a few hours, that would be great. Iptacopan is a small molecule complement-directed therapy that leaves the classical pathway intact. So sutimlimab as a C1s inhibitor inhibits the classical complement pathway. Iptacopan as a factor B inhibitor inhibits the alternative pathway of complement. And so iptacopan is currently in a phase 2 basket study in ITP, of which I'm the overall PI for that study, evaluating iptacopan in patients with ITP as well as cold agglutinin disease. And so we're very excited to see if this drug is efficacious in these patients. It's unlike sutimlimab, it's an oral drug, which would be more convenient, obviously, for patients. All right, and with that, I'm happy to take questions in the Q&A. Thank you very much.